Emergency preparedness are disaster situations. A disaster is defined as a threatening or occurring event of such destructive magnitude and force as to dislocate people, separate family members, damage or destroy homes, and injure or kill people, per the American Red Cross. Disasters are going to challenge emergency and healthcare services. A disaster will exist when the number of casualties exceeds the resource capabilities of the area. So, disaster criteria has to be defined by individual facilities. What may be normal for a large urban facility would be a disaster in a small rural facility. So consider, I don't know how many of you are aware of the Greensburg tornado, a very small town, but a large portion of the town was wiped out by an E5 tornado several years ago. Because its facilities were very small, they didn't have the resources to begin with, but some of their resources, including the hospital, were so severely damaged that they were unable to respond. So it did require the resource capabilities of surrounding towns to assist in emergency management. Whereas if we had that same situation in the KC Metro, we have so many emergency facilities available that we would be able to handle that type of event much better than the small town. So in the small town, it's a disaster. In the larger metro area, it may not be a disaster. So we also are going to base our disaster criteria on the time of day or the day of the week because we don't have all of the staff available, such as respiratory therapy or physical therapy, or let's say the operating room staff, etc. So some of our resources may also be limited. And that's especially pertinent in some of your smaller rural facilities compared to your large metro facilities. Different disaster types include natural disasters, which may be composed of earthquakes, floods, tsunamis, hurricanes, tornadoes, and wildfires, or human disasters, which could be explosions, fires, acts of terrorism, and it can be intentional or unintentional. Then we have internal versus external. Internal is going to be within the facility and may include a fire, explosion, a loss of critical utilities, or violence. External would be those natural disasters or biological concerns, terrorism, or malfunctions, such as with a nuclear reactor. Bombs are going to be designed to explode on impact or when detonated. They're designed to kill people, damage, or destroy property. So we see an immediate loss of life and health crises. Post-explosion injuries can include radioactive substances from gamma or ionizing radiation, which can penetrate, damage, and destroy body cells. Types of radiologic disasters can include an explosion of a dirty bomb that causes damage to or human error. Or, I'm sorry, another cause would be damage to or human error in a nuclear power plant or a nuclear blast. These can include the improvised explosive devices. They don't usually produce radiation, but the shrapnel from these bombs can cause significant or lethal injuries just as much as the pressure from the explosion can. So realize that the explosion itself creates so much pressure that it can cause significant bodily harm. But IEDs are designed to kill and or injure as many people as possible. A dirty bomb is defined as a conventional explosive device that spreads small amounts of radiation in the form of powder or pellets. And an example of that would be dynamite. A nuclear power plant disaster may be caused by devices that can initiate, control, and sustain the nuclear reactions, and they raise concern for escape of radiation. If there is a nuclear power plant in a community, the community is required to have enough potassium iodide to treat the entire community. This is a prophylactic treatment that helps protect the thyroid gland from radiation absorption. A nuclear blast would be an explosion that produces intense waves of heat, light, pressure, and radiation. With nuclear blasts, then we have the fear of fallout, where we have external radiological contamination and internal radiological contamination. Wind can carry fallout for long distances. What is really important to understand is um, our predisposing conditions, health conditions, can have an effect on how we're affected by these nuclear blasts. How much or how many things are between us and the radioactive waves? Um, how well are we protected? How are we shielded, basically, from the radiation? These clients may have burns, trauma from the force of the explosion or the heat. They may have invisible gamma radiation that penetrates the body and then will be eliminated in body fluids such as blood, sweat, urine, and feces. These clients may develop what we call acute radiation syndrome, and they can die from this. Long-term effects, they may develop all these cancers. There may be genetic effects in infants or congenital malformations, stillbirths, or impaired growth and development in children, and definitely shorter life expectancies. Very important to limit external and internal exposure to radiation. We need to reduce the radiologic organ damage by administering substances that interfere with the organ concentration or speed up the removal of that radioactive substance. So once again, to limit external contamination, which occurs from exposure to fallout that falls on the skin, hair, and clothing, clients should stay indoors, go to centrally located rooms or a basement that has very few windows. Turn off all the fans, air conditioners, forced air heating units. Put clothing and shoes in a plastic bag and then shower and wash with soap and water after the contamination, because radiation is going to be on the clothing and in the shoes. To limit internal contamination, this will occur when fallout enters through an open wound, it's inhaled or consumed through contaminated food and water. Clients should cover their mouth and nose with a scarf, handkerchief, or cloth. Drink only bottled water. Consume canned, dried, or packaged food products. Nothing fresh because of the potential of contamination. And avoid inhalation of tobacco products. We reduce radiologic organ damage by taking substances such as the potassium iodide, Prussian blue, and other substances. Biologic disasters are ones in which pathogens or their toxins cause harm to humans or other living species. How do we know there might be a biologic disaster? Well, Now we start to see high outbreaks of clients with similar symptoms. We have an increased number of sick people. The illness may be atypical, so it's not what we would normally expect. Or we have clusters of sick people in the same area. High mortality rates following a brief illness, unexplained death or illness of domestic or wild animals. It is classified into three categories, A, B, and C, according to its risk for national security. The three high priority agents in bioterrorist warfare include anthrax, botulism, and smallpox. They are a high threat because they're stable, they're simple to mass produce, they're easy to deliver to a large amount of people, and they're associated with high mortality and significantly increased public fear. Now, they're not necessarily going to kill everyone that is exposed, but it may just cause a significant illness, which would incapacitate population's ability to respond to emergency situations. But it will also kill a large number of the people that are exposed. So anthrax, this is a spore-forming bacterium. It causes disease when it's inhaled, ingested, or introduced into non-intact skin. Once it's in the body, then the spores will multiply and begin to produce toxins. With inhalation, these clients may have cold or flu-like symptoms that progresses into severe respiratory distress and or death. With ingestion, nausea, vomiting, diarrhea, abdominal pain definitely affects that GI tract. It can also affect the circulatory system and the mesenteric lymph nodes. On the skin, we see painless lesions on the head, hands, arms that may develop into black centered blisters that then ulcerate. Standard precautions are sufficient when caring for these clients. We diagnose it by culturing blood, stool, or wound exudate. We treat it with antibiotics such as ciprofloxacin, Levaquin, and the treatment should last 4 weeks, sometimes longer. There is a vaccine that is administered to military personnel and at-risk civilians. So you're a nurse who has to care for a victim of anthrax. The assessment findings of the infectious process associated with anthrax include and that's the painless lesion with a black centered blister. So botulism is a disease that develops from a neurotoxin produced by Clostridium botulinum. It is an anaerobic bacterium. It can be foodborne or transmitted through inhalation. These clients will experience paralysis of the motor and autonomic nerves, drooping of the eyes, generalized muscle weakness, and paralysis of the respiratory muscles. Early signs, we call this the 4Ds: diplopia, double vision, dysarthria, dysphonia, and dysphagia. So initial treatment will follow clinical rather than lab. In other words, we're going to treat the symptoms. They may require mechanical ventilation and the botulinum antitoxin. Smallpox is a highly contagious disease caused by the variola virus. It's spread 3 ways: through direct contact with an infected person, contact with body fluids, or contaminated objects that contain the live virus, or exposure to aerosol that contains the virus. These clients are usually asymptomatic for the first 7 to 14 days before a rash begins to develop. Then they also develop a high fever. The rash will start on the face and then it progresses to the extremities. Then it moves to the trunk. So variation in appearance from chicken pox is the smallpox starts on the extremities and it progresses to the trunk with a rash on the palms and the soles of the feet, while chickenpox begins on the trunk and spreads to the extremities, and it's rarely found on the soles of the feet or the palms of the hands. In addition, smallpox lesions are going to be the same degree of development, whereas chickenpox actually has multiple crops. In other words, they're going to break out, those lesions begin to crust over, they begin to heal, and they have additional breakouts. So they have multiple crops in differing stages of development and healing. Chemical disasters result from the release of toxic man-made substances that have a potential for causing mass casualties. Release of chemicals can be caused from industrial accidents or transports. Terrorists use it as weapons. It may include cyanide, respiratory toxins, or blistering agents. Indications that there might be a chemical terrorism act is we have dead or dying animals and or vegetation, an unexplained odor, there might be a fog-like or low-lying cloud in the atmosphere, abandoned devices that are used for spraying chemicals. And if this is an airborne, such as with the fog-like or low-lying cloud, then understand that that can be disseminated by wind conditions. So the nerve agent poisoning is the most toxic of all chemical agents. It can cause fatal consequences by inhibiting acetylcholinesterase. Example would be insecticide malathion. With the nerve agent vapor, the symptoms can develop within just a few seconds. In the liquid form, they usually will show in minutes to hours. Dermal exposure symptoms will appear as late as 18 hours after exposure. If inhalation is the method of transmission, death can occur within 10 minutes if an antidote is not administered. So drugs that we do administer to potentially help would be atropine or diazepam. We're going to give supportive measures, move clients to fresh air and give oxygen assisted ventilation, remove their clothing while wearing gloves, and then put their clothing in a sealed container. We have to wash areas of their skin that have been exposed to the chemical. Cyanide poisoning. Cyanide is a solid salt or a volatile liquid chemical, and it will cause death in minutes. It's used in gas chambers to execute prisoners. It can cause tachycardia, cardiac dysrhythmias, rapid breathing, low blood pressure, restlessness, dizziness, headache, change in the level of consciousness, respiratory failure. But just because it's cyanide does not mean the client will appear cyanotic, because they don't. They may also have an almond smell to their breath because cyanide is made from almonds. It's important to wear protective garments and respiratory masks, and we administer a cyanide antidote, which is amyl nitrate, sodium nitrate by IV, or IV sodium thiosulfate. The respiratory toxin poisoning are done with chemicals that primarily cause pulmonary edema when it's inhaled, such as chlorine or phosgene. These clients may have tearing, coughing, bronchospasms, laryngospasms, airway obstruction from edema. It produces a dermal injury that's similar to frostbite or thermal burns. We can avoid fatality by assisting the victims to fresh air, higher ground. A lot of chemicals are going to be closer to the ground, so if we can get higher, we may be able to get out of the chemical. Remove the victim's clothing and wash the skin with soap and water. And don't forget those contact lenses. Blistering agents are vesicants. They're chemicals that damage exposed skin and mucous membranes on contact. And this includes the respiratory tissues. They can also penetrate fabric. An example is mustard gas that was used in the Vietnam War. Assessment findings: the skin itches and it becomes red and blistered, and those blisters are going to be dome-shaped lesions. They're filled with a clear or yellow fluid. With inhalation, there is almost sure death within 24 hours because of airway obstruction caused by the blisters. Long-term effects: cancer, blood dyscrasias, infertility, and fetal abnormalities. An exposed person should be decontaminated immediately, which includes removal of all of the clothing and bagging the clothing, irrigating the victim's eyes, giving that vesicant antidote if available, and taking care of those skin lesions as we would take care of burns. Breathing by mechanical ventilation is likely to be required and may require blood transfusions. So let's talk about how we manage disasters. Emergency management is going to be the organization of the resources that are needed to help in the event of one of these disasters, including anything from policy planning to manpower. Phase one of emergency management includes mitigation, also known as prevention. It begins before the disaster to help prevent additional disasters. It helps reduce further occurrences and limits damaging effects. It raises awareness and decreases risks to minimize any potential damage that can be caused by an event and reduce further occurrence. Nurses in this phase are going to provide education and immunizations. Phase two is the preparedness phase. It takes place before the disaster occurs and it basically develops a plan for saving lives. So it's a plan just in case. Policies and procedures that should be set in place in the event of an emergency for pretty much every facility. Nurses are going to make sure that the public is educated on what to do in the event of an emergency, such as where do you go and do you have what you need to survive at least 3 days if you are unable to evacuate an area. The nurse's role also includes participating in drills and having a good understanding of the protocols that are in place and help in the development of policies and procedures. Who better to help develop these policies and procedures than the people who provide the majority of the patient care? The third phase is the response phase. This takes place during the disaster to limit injuries and deaths and reduce property damage. It's also known as the search and rescue phase. There are a lot of organizations that do provide relief in the form of food, shelter, healthcare aid, and protection from further damage or harm. The nurse's role: educate the clients on reducing fear and anxiety, facilitate communication and care of those in need while assessing the mental and physical needs of everyone in the area so we can provide treatments to meet those needs. So we also assist in triaging and treating clients. And then the fourth phase is the recovery phase. This takes place immediately after a disaster occurs and helps the community return to normal and restore safety for the public. Disaster victims will usually go through the stages of grief and often experience post-traumatic stress disorder. Nurses' role: assist in the revision of disaster plans as needed and provide client physical and emotional care. So prior to the disaster, nurses will contribute to the development of internal and external emergency response plans. We need to help prepare the public in case of a disaster by figuring out what we're going to do to take care of special populations, such as the older adults or those who have mental disabilities, etc., children. We need to teach about safety to include hygiene, food preparation, drinking water, human waste management, etc. We teach about infection control measures. So drinking water, we educate, can be obtained from hot water heaters, toilet tanks, not the toilet bowl, but the tank contains 2 or 3 gallons of water. We can add 1/8 of a teaspoon of chlorine to 1 gallon of water and then let it set for 30 minutes. And then we can drink it safely. We can filter debris from water from using a coffee filter or multiple layers of cloth. But then we also need to boil it for at least a full minute of a full rolling boil. In other words, it needs to be boiling hard. We educate that food in the freezer will remain good for 48 hours. But, if power is not restored within 48 hours, what do they do with the food? Do they know how to preserve the food? Plastic grocery bags or trash bags can be used to line a toilet bowl for human waste, not necessarily the urine, but for the feces. And then we also want to collaborate with medical command physician to meet patient needs. So with triage, the goal of triage is to provide the greatest good for the greatest number, and this involves recognizing the futility of trying to save clients that are likely to die, and then we care for the clients that can be saved. This will include doing a very quick head-to-toe assessment and then initiating that triage system. Nurses are also going to provide comfort and emotional support. We administer first aid to victims in immediate category by keeping their airway open, covering their wounds, controlling bleeding, splinting fractures. We can delegate the care of those that have minimal health needs to volunteers that have first aid skills. Personal emergency preparedness plan should be in place for all nurses. This allows the nurse to respond to a facility during a disaster. This would include creating a contact list for everyone in the household to carry. In other words, who am I going to contact in case of an emergency? Mom or dad has to go to the hospital to help take care of patients. So where do I go? Determine how to receive emergency alerts and develop an evacuation route and shelter location. So how am I going to get out and where do I go? We should also educate the public on a personal readiness supply or go bag. It will contain clothing and survival supplies to allow for a rapid evacuation. There should be at least 1 gallon of water per person per day for at least 3 days. There should be a 3-day food supply, and this should be non-perishable foods. There needs to be a battery-operated radio and extra batteries, a flashlight, a first aid kit, a whistle to signal for help, masks, soap, disinfectant, hand sanitizer, plastic sheeting, and duct tape can be used to create shelters, moist towelettes and garbage bags, wrench or pliers to turn off utilities, a manual can opener, local maps, prescription and non-prescription medications. If a client wears contacts, they need their contact solution and glasses, pet food, cash or traveler's checks. Don't be concerned about the debit cards or credit cards because they may not be able to work in a disaster. Important family documents, a sleeping bag or blankets per person, change of clothes and sturdy shoes, fire extinguisher, matches, toiletries, paper plates and plastic cups or utensils, paper and pencil, and activities for children. Now, I understand not all of these things may be able to be gathered, but these would definitely improve chances of survival. So, an emergency preparedness plan for facilities is mandated by the Joint Commission. All accredited healthcare organizations will take an all hazards approach to disaster planning, and then they participate in drills on a regular basis. These drills should conceivably contain elements that the healthcare team may encounter in the geographical location they're in. In other words, if you live next to a river, you may need to uh, do drills for floods. If you live in California, earthquakes. In the Midwest, tornadoes, bombs, avalanches in the mountains, etc. And this includes not only hospitals, but also long-term care facilities and rehab facilities. Uh, Medicare is going to require every healthcare facility to practice at least one fire drill or actual fire response annually. Some of the organizations that may respond to a disaster would be the National Guard, American Red Cross, Public Health Department, military units, Medical Reserve Corps, Disaster Medical Assistance Team, and those can all be activated by state and federal governments. So let's look at the hospital itself. The Hospital Incident Command System will have a facility level organizational model to manage any disasters. We start off with the hospital incident commander. This is the person who is in charge. They assume overall leadership for implementation of the facility disaster plan, and they may require shifting of patients or staff, for example. They determine when to call a disaster and when to stand down, excuse me, or deactivate that emergency response. Then we have a medical command physician. This physician will focus on the needs of the clients and what resources may be required to care for the clients, such as a surgeon. Uh, let's say there was a large motor vehicle accident, multiple vehicles involved. Disaster is called. They're going to require orthopedic surgeon. They're going to require general surgeons who can operate to stop potential internal bleeding, etc. So they want to make sure that they have the appropriate number and appropriate type of physicians available. The triage officer will be the person who's in charge of triaging and tagging incoming clients to determine the appropriate disposition of the clients. And then we have a communications person. This is going to be outlined in the disaster plan by providing guidelines for managing media requests, including a designated spokesperson. And this designated spokesperson should also provide information to families as it becomes available. After a disaster, then we have event resolution and debriefing. We have a critical incident stress debriefing, and this is going to be more for the people who are involved in treating victims of the disaster. It allows them an outlet to discuss the incident and to learn how to deal with the emotional stress. Those healthcare workers can have post traumatic stress disorder following the working of a disaster. And then there's an administrative review that will determine if the event was handled appropriately or what improvements might be initiated for potential future events. Excuse me. Decontamination will be the process of removing accumulated contaminants or rendering them harmless. It's critical for the health and safety of the healthcare providers by preventing secondary contamination. And it includes two steps. Step one will be the removal of the client's clothing and jewelry and then rinsing the client with water. Step two will be a thorough soap and water wash and rinse. A nurse manager is educating the unit staff on the indications of a chemical release. The indications of chemical terrorism include which of the following? This is all of the above. So priorities for nursing is going to be death, severe hypoxia, impaired skin integrity, risk for infection, and ineffective coping. A client is exposed to a thermal burn and is at risk for impaired skin integrity. The nursing interventions related to the care of this client include applying a semi-occlusive dressing over the wound. Now let me review the triage. I realize that I did not cover that. Triage consists of different categories. Black is going to be the client that is already dead or is not likely to survive even if emergency treatment is provided. And it's going to be very difficult for nurses to walk away from these clients to treat those who are likely to survive. Red will be the category that is emergent. I have to take care of them right now because if I don't, they will die. This would be someone who has, for example, chest pain. They may be experiencing a myocardial infarction, or they have issues with respiratory status, such as, let's say, a pneumothorax, and we have to take care of that pneumothorax right now because if we don't, they will die. Um, so, in other words, if we provide treatment right now, we are likely to save this client. The next category is going to be yellow. Yellow is going to be urgent. They should be seen as soon as possible, but they will not die if we don't take care of them right this minute. they can wait up to about 4 hours prior to receiving appropriate treatment. So they need to be seen as soon as possible, but they do not need to be seen right this second. And then we have green. Green is what we call the walking wounded. These are going to be the clients with very minor injuries or issues going on. These clients can wait up to a full day before we take care of them. And then we have evacuation. There's a variety of reasons for evacuation. It could be a fire, a chemical spill, terrorist act, a bomb threat, etc. Every facility should have a disaster plan in place for a variety of situations that outline the expectations of the staff and procedures that should be followed. It is the responsibility of every staff member in the facility to be familiar with these plans so they can respond appropriately and assist clients or visitors to safety. If evacuation is not necessary, but there is a risk of airborne contamination, clients should be taught to place wet towels in any cracks, such as doorways, close windows, turn off fans, air conditioners, etc. In a facility with evacuation, again, review the facility's disaster plan so you know which action nurses in specific units should complete. Usually, we're going to move the clients that are most easily evacuated first. In other words, these clients can be moved by less medically trained staff. The more critical clients would be removed second because they require more medical training and more uh, potential equipment to transfer them, including the use of portable ventilators or bag valve masks. And we also have to consider how we're going to get non-ambulatory clients vertical. So in other words, how do we get them downstairs? Because elevators probably are not going to be operational during an emergency situation. With fires, for example, we may evacuate them horizontally. In other words, we go to a different area on the same floor, go beyond fire doors, because of course we don't use elevators in these situations. And now your post test.